Welcome everyone to tonight's webinar, Emotional Regulation from an Occupational Therapy Perspective. I begin by respectfully acknowledging the Wurundjeri Woi-wurrung people of the Kulin Nation, who are the traditional owners of the land on which I stand and am hosting from today. In the spirit of reconciliation, NEABPD Australia acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respect to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people attending here today. We also acknowledge people with lived experience of mental ill health and recovery, and the experience of people who have been carers, families, and supporters. My name is Belinda and I will be your host today. I work and volunteer for NEABPD Australia in our virtual head office, and I am also a trained volunteer family connections leader. You probably already know that NEABPD Australia is a not-for-profit organisation, and we deliver programs, webinars and events to support families and carers and people in a relationship with someone who has BPD or BPD traits. And that's whether there is a formal diagnosis or not. I'll chat a bit later about our main offering, which is the Family Connections program. But just in brief, it's a free evidence-based 12-week program which delivers psychoeducation, skills training and support for people who are caring for or in a relationship with someone with BPD. Today, we are so grateful for a presentation from Alison Hopwood, who's an occupational therapist from Tasmania, as she established Independence Kids Occupational Therapy in 2008. And Alison has worked with children and young people for over 30 years. Thank you, Alison, for making the time for us and our audience. Welcome.
Thanks, Belinda. So first of all, hats off to your organisation. You're doing an amazing job. We are referring a lot of people through to you guys at the moment and your parenting program. It's just been phenomenal. And we're just seeing such appreciation for what you're doing. So thank you. And also thanks for inviting me tonight. And actually thanks to Steve, my brother, who put my hand up for me, and here we are. So we've actually got quite a few people here from Independent Kids and Adults tonight, and also a few of my other family members, which is really lovely. So I'm going to share my presentation with you all, and as Belinda was saying, that we can stop and have questions at the end, and some of you may have actually had interaction with an OT before, and some of you may not. So we're going to be going through information about what an OT does and a whole range of things, and how some OTs might work around looking at emotional regulation. So I just want to double check that you can all see the PowerPoint presentation. Is that right? You can all see it okay? So a little bit about me, just like Belinda was saying, I'm an occupational therapist, and I graduated from university in 1989, which seems like such a long time ago, and it was a long time ago. And since that time, I've been working with children, adolescents and young adults. I'm the owner of Independent Kids and Adults, and that, as Belinda was saying, it started in 2008, and that was just me driving around in my beat-up car, and now we've got 45 staff, which is a team of OTs, behaviour support practitioners, physios and early educators. And we work with a wide range of people across the lifespan. So some of our people have been seeing us since they were very young and are now adults, which is really lovely. And a lot of our work actually happens within the National Disability Insurance Scheme. So OT is an allied health discipline that really looks at an individual's capacity to engage in meaningful occupation. And occupation can be things like your daily living skills, like washing, showering, dressing and toileting, your social interactions, how you learn, your work, your relationships, your household management, your household tasks and management like cleaning and cooking and finances, and how you might participate in the community. So it's quite a broad discipline, but the main thing that we look at is what would be the barriers for you being able to achieve these these skills or these occupations? What stands in the way between you and being able to do those things? So when we look at identifying the barriers, we would look at different models of practice that assess a person's overall capacity and what the barriers might be to that person engaging in their everyday activities. And so we would then look at a person's physical capacity, their sensory capacity, their psychosocial capacity, and also really understand their own unique neurological profile and how things work for them. And that's a big part of what I'm going to be talking about tonight. So a lot of talk more recently has been coming around about neurodiversity. And neurodiversity is really around that every brain is formed differently. And that's been based on your genetic profile and your experiences. So that formulates how your brain grows and develops. So while 80% of the population tend to have a more common brain type, there's 20% of the population, or there's believed to be around 20% of the population that have brain structures that might be slightly different. And these neurological differences can really have a really profound effect on your emotional regulation, your way that you interpret and see the world, and a whole range of things. Now, within that 20%, though, that 20% is mainly looking at people who are autistic, ADHD, dyslexia, dysgraphia, dyscalculia, but it doesn't actually take into effect some of the other neurological difference which would come with with those psychosocial kind of diagnoses. So when we look at diagnoses as well, so say if we're looking at a diagnosis of autism, that the diagnostic criteria for autism are based largely on a set of behaviours that you would see in somebody when they're under stress. And so that's the same for borderline personality disorder. It's a cluster of symptoms that we might see in a person whose system is under stress.
The Australian Medical Association and Consumers Health Board and others stood up in
Linda?
President saying double dispensing.
So I guess then what we're seeing is we're identifying a cluster of symptoms that somebody shows when they're under stress, and our job is to find out where that stress is coming from. What is it about that person's profile that is giving them, that is making that cluster of symptoms happen? Does that make sense to everybody? Nods and stuff are great for me. So then when we're looking at neurodiversity, we would then start to look at how we would work with a person in a neuro-affirming way. And that means that there is just neurological difference, or there is just difference for each individual person. And there's no good or bad about that. It is just difference. And it's just like people would have physical differences, like some people have different height, some people have different hair color, some people have different blood type. They might be more sporty than others. Just like that, everybody will have neurological difference. And when we understand that neurodivergence is a natural phenomenon, it shifts us into a different model of practice. And the model of practice that we would look at now is the model of human rights. So in the past, we really worked from a medical model where it identified that the person held all the problems, and it was the person that we then had to treat or fix. Then it moved to a charitable model where everybody else was sort of trying to help the person. Then we moved to a social model, which in a social model of service delivery, that really looks at us changing the environment for where that person might be. And then a model of human rights actually looks at how can we actually all work together to ensure that everybody has choice and control, is able to advocate for themselves, to be able to change environments to match their needs. Now, while this all sounds a little bit off the topic of what OT does, or what how I can help you with your person, or with you who might have BDP, this actually all shifts into the type of care then that we would actually, how we'd segment out somebody's treatment program. So in the medical model, there was a lot of blame and a lot of focus on the individual as holding all of the issues. Whereas in the social model, it really sort of looked at what are the barriers for this person in being able to participate in their everyday occupations. And then, as I was saying that the human rights model really took the social model and looked at empowerment through a strengths-based approach. So then what happens with this approach is the first thing that we would do is really understand a person's individual profile, their neurology, their responses to situations, including their strengths and their areas that they might require support. We'll then work on educating the person and working with the person on understanding their own profile with the aim of building empowerment and self-knowledge. Then we'd work with educating others in that person's life on actually what their profile is so that everybody else understands their profile. And then from that, we would look at environmental adaptation. And by that, I mean is actually building and enabling environments that best suit everybody's needs, including that person's individual profile. After that, we'd start to look at adapting tasks to match that person, and then we'd look at skill building. So the skill building part, which is often the face-to-face therapeutic part of it, is actually tiny compared to that big global shift. So when we're working with a person, we would start at the top, which is really about everybody understanding that person's individual profile and why their brain ticks the way that it does. So emotional dysregulation is when you have big emotions that may not match the situation and you feel out of control. You might have big angry outbursts, and that leads to lots of spelling mistakes, because I did this just before now, self-damaging behaviours. So when we're looking at something like DBT, dialectical behaviour therapy, that uses a biosocial theory where we say that for each person there is biological difference. So somebody might have more sensitivity to emotion, more sensitivity to sensory information. That plus an invalidating environment leads to those big periods of emotional dysregulation. And I'm assuming that if a lot of you have already done the Family Connections course, that you would have talked a lot about this, the biosocial process. Is that right, Belinda? Can you give me a nod or a shake on that? Yeah, great. So then what I'm going to talk about today is biological difference from an OT point of view and invalidating environment from an OT point of view as well. So when we look at biological from an occupational therapy point of view, we would first of all look at sensory sensitivity. Then we would look at emotional sensitivity. We would also look at social competency. We'd look at trauma mapping, planning and organize, so how somebody can plan and organize themselves, attention. And when disrepair or disruption occurs because of a person's neurological uniqueness, that can then map as trauma. And so some people actually might map their the way that they process information as trauma, even if a clear trauma event hasn't happened. Does that make sense, or do you want me to go over that in a different way? That makes sense? Yes? Yes, no, I can only see a few faces, so nods and shakes are great. So then that mapping of trauma then influences your window of tolerance. So the window of tolerance was a theory that was developed by Dan Siegel. And what he sort of talks about is that everybody has their own unique window of tolerance. And their window of tolerance is how they can tolerate or deal with anything that's coming up in their everyday life and stay within that window of tolerance without getting over responsive or going into hypoarousal. So you can experience a big range of emotions when you're in your window of tolerance. You can experience sadness, joy, frustration, but still manage to regulate your emotions and behaviors enough to actually manage those feelings when you're in your window of tolerance. Now, according to your own neurological profile, that will actually influence how big or small your overall window of tolerance is. So for somebody who has BDP, they would have a small, tiny, sometimes non-existent window of tolerance. And that means that they're often pushed outside their window of tolerance and go into a hyperarousal state, which is when you become anxious, overwhelmed, angry, lash out, fight, yell, scream. Or they might flip down into hypoarousal, which is that spacey, zoned out, dissociative kind of state. And the research study also indicates that you can flip between hyper and hypoarousal or be in both states at any one time. Now, according to your neurological mapping, whether that's from a traumatic event or from your own neurological mapping of trauma-based pathways, that will sort of influence how big your window of tolerance is. And also with your window of tolerance, if you're under stress, that will become a lot smaller. So your window of tolerance can shrink during times of stress, like I was saying. And it is also unique to you and your genetic makeup and your experiences. But we know that with support and validation and strong relationship and work, you can actually broaden and make your window of tolerance bigger. So I've just popped a little video in there, and at the end of the session tonight, a link to a video. At the end of the session tonight, I'll forward these slides on to Belinda, probably without the spelling mistakes being fixed. And then she can forward this on to you so that you guys can look back through these slides and also link to some of the resources that I've popped in here as well. So from a biological point of view, one of the things that occupational therapists look at a lot is sensory processing. And sensory processing is how we take information from the external world, process it, and use it for function. So we've got a number of different sensory systems that take information from our environment. They're our auditory sense, which is the one that gives us an understanding about noise, touch, smell, visual, which is sight, movement, which is called vestibular, and proprioception, which is our body awareness. Now, these systems are working all the time, all together to actually tell us what's happening in our environment. And one of the big things about these systems is they have to tell us if there is any point of threat coming in. Now, for some people, their systems are actually wired to treat what we would consider, what a typical brain would map as a non-noxious stimuli as a threatening stimuli. So for some people, what would happen is they would feel touch and their brain would say, oh, look out, this is going to be dangerous. You better get ready to defend yourself. You better head into fight, flight. So for some people, and I'm going to say kids because we often see it a lot with young children, but then of course, if you've got sensory over-responsiveness, you're going to have that same neurological profile when you're an adult. The sensations coming in actually map as if they're going to be dangerous. And the way that happens is that all of your sensations, except for smell, come in through the bottom of your brain. And it's the function of the bottom of the brain to tell you how much of that information you have to tune to that's relevant to the situation you're in. So right now I'm sitting in my office, which happens to be in the back of a house, in its garage, and all the other office spaces are down the other end of the big house. But I'm sitting here all by myself in the dark. And so if a big noise happened, my sensory system would say, quick, you better tune to that. That could be dangerous. Look out. Now, for some people, and then I would have a fear response and you'd see me run off and try and deal with that or run away. Now, for some people, that happens even if it was a familiar noise, like the sound of a car driving past or the sound of people talking as they walk past. And that information then flips up to your limbic system, which is your emotional control system, to say, get ready because this is going to be dangerous. So it means that people who have sensory over-responsiveness are in a constant state of high alert, and that actually maps a brain that's experiencing trauma. So examples that we might see for sensory over-responsiveness is that somebody might be sensory over-responsive to touch. And that could look like they don't like hugs or touch, they don't like light touch, they get irritated by certain clothes, they can't tolerate hair brushing, they can't tolerate teeth brushing or nail cutting. And if somebody brushes past them lightly, they might hit out or have an aggressive response. Some people might be over-responsive to sounds. That might be that they don't like certain sounds, they put their hands over their ears, they get upset in noisy environments, or they notice sounds that others don't. Some people might get defensive around movement, which they might not like certain types of movement. It might be things like riding a car makes them sick, or they don't like being off the ground, or as babies, they didn't like their heads being tipped back, or they might feel really uncomfortable on unstable surfaces. And then for some people, they might be hypervigilant to smell, and other people might have sensory over-responsiveness to visual input, which means they notice everything in the room, they notice small details, and they're distracted by visual input. So when you've got a system that is wired to be over-responsive to sensory input, that actually leads to big emotional uncontrolled responses because your system is constantly in fight flight. And that leads to dysregulation, which can be big meltdowns, big screaming attacks. And that when you're in that state, you have a constant release of cortisol, which is your stress hormone. And that's what we see in people who have significant trauma backgrounds. Another area that an OT would look at is somebody's ability to organise themselves to move efficiently through space and to sequence all the tasks that they need to do. So this would sort of fit into a profile that we would call dyspraxia. So it's the job of your cerebellum, which is a little sort of mini brain under your brain, to organise your movement, your understanding of your body in space, and your sequencing and planning. So that comes from your vestibular sense, which is in your ear, your movement sense, understanding where your body is in space, and deep touch. And they always all work together to give you a map about what your body has just done and what it needs to do a task. So for some people, the cerebellum doesn't organize that information very well. And it means that coordination, learning new movements, sequencing your thoughts, organizing what you do throughout the day is really tricky. And that means that the tasks that you have to take to do throughout the day actually take a lot more effort, and they don't become automatic. And it's that process of having to work so much harder throughout the day that can lead to dysregulation, especially as the demands of the task outweigh your capacity. So what might seem like a simple task to somebody else could actually be an incredibly difficult task for somebody, and that leads to dysregulation, big emotional upset, maps as trauma, and you get a big cortisol release. The other area that we would look at is social challenges as well. And when we look at social challenges, some OTs might look at it from a social competency model. There's a speech pathologist in America called Michelle Garcia-Winner who really has had a look at the foundations of social competency and how social competency works. And what she says is the first thing that you need to be able to do in a social situation is pay attention to the whole environment. So that would mean if you walked into a classroom situation, you would look around the room and see what everybody is doing in that room rather than just focus on one thing. So social attention means being able to attend and take in a whole environment. From that, you would actually then interpret the situation. So you'd say, I can see everybody is sitting on the mat. And then you would problem solve. You would say, so that must mean it's probably morning circle time and everybody's listening to the teacher. And usually at this time of day, everybody sits down on the mat and listens to the teacher. So then you would have your social response, which is, the best thing for me to do in this situation is to actually go and sit on the mat and start tuning to the teacher. And then you would go back down and then you would do that and then do a quick assessment in your mind. If you think that was the right thing to do in that situation, then you go back down and attend to what was actually happening next. So we actually flick through this social processing model within milliseconds all day, every day. Now, if there's part of this triangle that is tricky for you because you're in sensory overwhelm, you have your own unique neurological profile that you find planning and processing really difficult, then there will be disruption to this social triangle that will then lead to confusion and mistiming that then leads to sort of like a stress response, which then again we're mapping it as a trauma cortisol releasing kind of response. So you can see that if people have their own differences and their own unique profiles, their own unique neurological profiles, there can be many different parts that can actually contribute to that mapping of trauma or mapping of dysregulation. So all of those stressful situations make you release your cortisol, which is your stress hormone, that give you a higher heart rate, that increase your breathing rate, that also give you shallow breathing, that give you hot, cold flushes, that reduce your attention and take you outside of your window of tolerance. But there's some counteracting hormones that we can actually work with that actually push down your cortisol and make you feel calm and happy. So some of those hormones that we would look at are dopamine, which come from positive relationship, reward, and pleasurable sensation. There's serotonin that come from exercise, weightlifting, resistance work, and sunlight. There's endorphins, which come from cardio work, moderate exercise, weight training, chocolate, palatable food, spicy food, wine, my favorite, and cutting, burning, self-harming. Also will release your endorphins. And then oxytocin, which comes through that's your love hormone that comes from, you release that when you give birth to a child, you release it when you're breastfeeding, and it's where you release it when you get cuddles, hugs, massage, also from yoga and pets as well. So what can an OT do to support emotional regulation? So the first thing that an OT can do is to work with the person and work with the family on understanding that person's or your own unique neurological profile. And that would be through assessment of sensory systems, looking at social capacities, attention, regulation, body organization planning. And then we would also look at identifying strengths and passions. We'd identify triggers and stress points, and then identify what works for that individual person's profile. And that's going to be different for each person. So then the next thing that we would look at is somebody's environment. And when we're talking about borderline personality disorder and also talking about DBT, one of the biggest things that we know that works is actually having a validating environment. And DBT talks a lot about relationship validation, like validating with each other, but actually creating a validating environment is a much deeper than that. So to create a validating environment is about understanding your own profile and acceptance of your own neurodiversity or your own diversity or your own psychosocial diversity. It's creating an environment that meets your sensory needs or your psychosocial needs or your motor needs. It's about creating activity that reduces cortisol release and increases happy hormone release. It's about creating an environment that supports relationship, that supports feeling safe, and that you can kind of build stuff that really creates your own happy hormone. So an example of that is I'm working with a teen and her parents at the moment. She has borderline personality disorder and has had a pretty rough time, as I imagine you would all understand. And the first thing that we've really done is really been able to sit and work through her profile And just being able to do that has made a massive change in her feeling validated that actually this is where it all stems from for me. I really understand myself now and my parents understand me. And then from that, then we have started to build her own environments that reduce her sensory over-responsiveness, that help her with her communication and language needs, and also split between two houses creates sameness across those two houses for her. And just over a period of 2 or 3 weeks of being able to do those couple of things, we've seen a massive shift in the whole family and a massive shift in her feelings of self-worth and her feeling validated. So creating that environment goes beyond just the relationship. It actually goes, creating the validation goes much beyond the interaction, but also around the environment. The next thing too is to really identify strengths for the individual person, because when you are in your biggest crisis points with BDP, being able to see strengths and being able to identify strengths is super tough, because it is just in crisis mode. So when we start talking about strengths, and just coming back a bit, so sometimes we might spend a lot of time just in creating and validating environments. We actually might not get past that until that person really feels like they're starting to come out of crisis. But what we're trying to do is really, really work with that validation, all the validation kind of principles, and creating the space and the understanding for everybody to be able to pull out a crisis. So then when we go into understanding strengths, an example of this might be that if you have an autistic profile, you might have over-responsiveness to sound, which makes it really traumatic for you to be in noisy environments. And while that can be seen as a negative, the flip side of that is that means that when you can use your hearing for specific timbres in sound or construction of sound that no one else can hear, that can be part of your gift. So part of the thing that you could do that nobody else could do that makes you an amazing musician. If somebody has a passion area that they just can't stop thinking about as part of their autistic profile, and it means that they want to think and live and breathe that passion area or their special interest, and most inventors' discoveries all happen by brains that were wired for special and intense interests, so autistic brains, the world wouldn't be like it is, because all of the major inventions that ever happened in the world actually happened from people who are autistic. So if you've got an ADHD profile, you might not have great attention and your brain may wander all of this, or your thinking may wander all the time, but you're actually a person who can think outside the box more than somebody who is neurotypical. If you're wired to have emotional sensitivity, while that actually might lead to extreme feelings of disrepair, that actually also can give you extreme feelings of joy when you are not in crisis mode. So there's always two sides to every bit of somebody's profile, and there's always strengths in somebody's profiles, and being able to see those strengths can be one of the most liberating things as part of your learning journey. The biggest part of working with somebody who has borderline personality disorder or big emotional responses is relationship. And it's relationship that gives you your dopamine hit. It's your relationship that gives you co-regulation, and it's your relationship that gives you safety and security. So relationship is definitely the foundation to regulation, and it is the one thing that gives you all of those happy hormones releasing. So when you're in relationship with somebody who has big emotional responses, the main thing is your own self-care, because if you are not in your own window of tolerance, then it is really tricky to be able to help manage somebody else to manage to come back within theirs. Now, I guess from my perspective, the reason why I started to really look at borderline personality disorder is because of my brother, Stephen, who's here tonight. and I have a daughter who also has all of the signs of borderline personality disorder, and we've been on a pretty big journey for the last 2 years. And so then I went off and studied a lot more about borderline personality and did my DBT training as well. So that was really great for me. So I understand where a lot of you are at. She definitely has shown all of her signs of all of these, all of her sensory sensitivities and a whole range of things since she was little. And then, of course, as her brain became more mapped for trauma, then she headed into her big emotional responses in her teen years. So what I sort of have learned through this journey is the importance of maintaining my own window of tolerance, because without that, then I couldn't be there to support her. So a lot of my work has actually been in the initial days around me understanding my triggers, my own sensory profile, my own window of tolerance, and what I can do to stay in there to support her. That is really, really helpful when you're working alongside someone. So when you're going through this journey, really look at mapping out and understanding your own unique neurological profile. When you actually understand your own profile and the profile of others, that actually provides safety for you and your person, or if you are the person for you. One of the biggest things for people who have borderline personality disorder or who have big emotional responses is they often need somebody else to support their co-regulation. And so when we look at this, look at the stages of co-regulation, when we have a tiny little baby, mum or dad do all of the regulating for that person. They rock and they pat and they hum, or they bounce them up and down to wake them up. And then it sort of shifts into more co-regulation, where the parent is really letting the child know that things are going to be okay, but the child starts to wander off a little bit in the world and comes back to when they need some co-regulation from the parent. And as they get older, they start to learn more self-regulation. Now, often for people who have neurological diversity or their own unique profile, that self-regulation is really tough, and they rely so heavily on their parents for co-regulation that they will come to you for co-regulation, but that often looks like yelling, screaming, verbal abuse, physical aggression, because they really have such a disordered neurological profile that they can't work out how to regulate themselves without drawing you in on that as well. So being able to validate is really important, as you would have learned through your work that you would do with family connections. And the biggest thing that is important in building relationship is availability. And I once had this very, very wise mentor who said to me, the greatest gift that you can give somebody is your attention. And when I mean attention, I mean your full attention, and to be available, to not be diverting to your phone, diverting to household chores, but to actually give that person your full attention. And that is actually one of the things that really supports relationship. We would then work on educating others about somebody's unique profile so that they understand how to create environments and interactions to support that person, just the same as we would educate somebody on how to do manual handling for somebody who had a physical disability, just how we would educate somebody on how to use a ramp for somebody who had a physical disability. So it's about building the knowledge of the community to actually understand somebody's profile, and then look at how the world can accommodate others and their own unique needs. And that can only happen through full understanding and acceptance. So it's about people being out there and championing for that person and their profile. Then we would actually really work with that person on understanding their own profile, building their self-advocacy skills so they can say, actually, I work best in an environment that's like blah, 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 blah. Or when I'm dysregulated, I need these things. Understand their own profile, understand their own uniques, and understand what works individually for them so that they can actually help others understand as well. So once we actually have a person who understands their profile, their family and their community understand their profile, we've looked at their environment, we've looked at relationship, then we would go down to, well, what is it that actually might be triggering within the tasks that are expected for this person, like within their occupations? And so we would always look at adapting what that person is expected to do to the just right challenge for where they're at that time. So if I was to think about that from a physical sense, I would say, oh, I can see my 3-year-old is really challenged when I ask them to put their shoes and socks on. But if I adapt the task to just actually need them to put their shoes on, but I help them out with their socks, that I've actually pulled that task down to the just right challenge, and I've diverted a problem or an upset or a meltdown. When I would start to go that into a complex set of psychosocial characteristics, then we'd say, actually, is it too much to expect that somebody can actually clean their teeth and have a shower in one day when they are feeling so horrid about themselves? Let's pare that down to the just right challenge where that person's at this time. So when the tasks are set too high, you get a release of cortisol, and again, that maps as trauma. When the tasks are set too low, they're not interesting. You have reduced attention and no dopamine hit, and you need a dopamine hit at the end of every task to make you want to do it and to make you want to do it again next time. And so if the tasks are set too low, then you're not going to be able to get a repeat on that task later on. So support difficult activities by breaking them down and make sure that you build in dopamine hits along the way. And then at the end of all of that, that's actually when you're ready to build your skills. And that is when you are ready to really be able to take in some of those skills that you might learn from DBT and build those skills within understanding your own unique needs. So I was a bit tired and stressed tonight because I've had a big presentation last night as well, and I've had a big day. And as I said, my daughter has been on a pretty big journey. And then she sent me this little poem tonight, which I thought, oh my goodness, look at where we've come in 2 years. She doesn't even know what I'm talking about tonight. But it was this really beautiful poem just about her recognizing that she has been well supported on her journey, which is brilliant, because my goals for her are to be alive in a year, and she is, which is great. And we've hit that goal really well. And so I'm just really proud of her and how far she's come. So hats off to you, because turning up tonight is amazing, and it is a massive step in this process. This is a long process, and it's the process that builds a skill, not the actual end result. So the process of traveling through this journey is actually what is building everybody's skill in this. And actually, there might not be a defined end result in all of this. It takes a village to actually make this happen. You can't do this on your own. You need support around you. And you really need other people's understanding of your situation and acceptance of that. And you all need your validation of that as well. And this is not about addressing this as a single person's problem. This is an environmental, a whole community's issue. Like, we treat this as a community-based issue. There's going to be ups and downs. And so really take time to celebrate your tiny wins, because those tiny wins, there might be a tiny glimmer in months of hardship, but really celebrate those tiny wins. And this is a life journey of growth for you all, as well as your people that you're caring for, or if it's you that has BDP, this is a life journey of growth. This is not something that necessarily be fixed or go away, but appreciate your own journey and what you all as individuals learn from this process as well. Be gentle on yourself, and you are all doing a really great job. I've just added in a few little resources on the end. One of the things that before I did my DBT training, that we have been very involved with, is a Circle of Security parenting training. And that's really aimed at kids who are toddlers, but I just found this fascinating because I feel like Circle of Security is a lifelong process of needing to come back into your carers for co-regulation and growth. And so I really like that, but there's a few other little tiny resources in there. But I might throw this back to Belinda now and open up for questions.
Thank you. I just need to open up the chat for everyone. We can, oh, here we go. I had to find where it was. Okay. Okay, so the chat is open now. If you've got some questions, you can pop them in there. We might go to some of the questions that came through, especially some of the late registrations and the pre-submitted questions. Let me just grab those.
Can I just also say as well that not all OTs have the same skill set, because as you can see, it's a really varied, the things that we do are really varied. There's not everybody out there that has the same skill set. I can see there's a lot of ICOP people here tonight, actually. So I'm also happy for them to chime in if anybody has questions as well. But please ask questions, because it's your chance now to get access to an OT. And they're pretty hard to get, pretty hard to get hold of.
So I've got a question here that somebody's asked. I'm curious as to if there is workplace support to help with emotional regulation. We have a number of autistic adults within our workplaces that often struggle, and the team struggle with that.
Yeah.
I've been trying to find support for these team members, especially related to them in the workplace.
Yeah, absolutely there is. It depends on where you live and to what's available there as well. But there's this really lovely little video that's been done on the social theory exactly around that by a organisation called Differing Minds. And I'm happy to flick that in with the presentation, but I think it's really worth watching that to provide insight into how that could happen.
Someone has asked for how to find BPD informed OTs. This is the question that we often get. That would be great to have centralized lists that you could find. But have you got any resources that you can point people towards?
Look, no. Sorry, okay. I don't. So I would just tend to Google DBT informed or OTs. And look, everybody's going to be different. This is kind of, I guess the information that I presented to you tonight, that's been our whole team working on our growth around these areas. And so this is kind of some of the stuff that we've come up with together as a whole team at Independent Kids and Adults. We've had probably, I don't know how many of us went through and have just finished doing some DBT work with myself and our team to understand the concepts of DBT and how we can integrate it into our practice as well.
Someone's asked, how do we best respond to immediate crisis? They've said that their daughter said that they're on the verge of a mental breakdown, and they're wondering what's the best place to start with responding to that.
Yeah, look, and I know that there'll be lots of people in the this virtual room tonight that would have lots of ideas about this, but I guess this is where your relationship is key, where you're validating, where you're available, that you give your full attention. And it actually might mean that you just have to be like, I'm now talking from a parent as well, but just to be there and be with that person and to validate and accept and don't judge and to understand where she's at. And then to work out together how there might be some ways to move forward with this. And it's going to depend on what's available in your area. Like the allied health services is just so stretched and they're so hard to get into. And unless you actually now on the NDIS, it's nearly impossible to get into an allied health service. It's tough out there.
We've got a question here. Have you observed a rise of BPD in the transgender community? Does this make finding identity more difficult?
I guess in terms of where I work, my main area of work is with people who are neurodivergent. So yes, there is a rise of diagnosis of BDP in people who are neurodivergent, because I feel that people have more understanding of BDP, and it's a diagnosis that's actually happening more often now to explain why somebody might have emotional dysregulation. I suspect that there's the same number of cases out there, but they just weren't previously diagnosed. And I can't sort of say around the transgender community, but I do work with people who are autistic, but also transgender, and also have BDP as well.
Yeah, just on that, I heard recently that the within the neurodiverse community, there's up to 20%, or around the figures they think are around 20%, are people who are going to present with some gender diversity and sexuality diversity. So certainly there's maybe a higher incidence of people in the neurodiverse community who are going to be presenting as transgender, amongst other gender expressions. Someone's got a question here. I'm finding it hard to co-regulate in my family situation, having a parent who lives with BPD. We have a program for that. Family Connections is wonderful. And I myself also have a parent with BPD, and I found the skills in Family Connections to be amazing for
Absolutely
supporting that relationship. From an OT perspective, Alison?
Yes, absolutely. And look, again, that's a little bit tricky to sort of comment on, because that's kind of like opening the can of a very big lot of worms, and there's so many. It's really hard to actually give clinical advice when I don't understand the whole situation. But I guess what I would say is really come back to those foundations of understanding somebody's profile, understanding how to best map out that environment to suit that profile for you both. Look at where the triggers are, identifying your strengths, and being able to get support for some of that is really great.
Mm-hmm. We've had a few questions about how does one go about finding their own and discovering their own profile, and then I guess working with that.
Yeah, look, again, it's about finding the right match of therapist for you and being able to access somebody who might be able to help you with that. I have tucked in a few little places that you can go to that you might start to be able to understand a little bit more about some of the things that I was talking about. And then, so yeah. I can also see a question in there as well about co-regulation. What was that question again?
I think, was it how do we support someone to calm when they're in the middle of a meltdown, when they're not capable in that moment? I think there's been a few different
versions of that. Yeah, that's so tricky. It's so tricky, and it takes a lot of practice and a lot of working together on that. But coming back to those key foundations of understanding somebody's profile, helping them to understand their profile, and that connection and relationship are the three biggest components that are going to give you effective change to be able to engage other strategies as you shift along. And it's not something that can happen in an instant either. It's a lot of practice. And look, there's some language which comes out of DBT that's amazing, like to validate somebody else, to not offer solutions, to understand the emotions, to not use shoulds and shouldn'ts in your way that you speak to people, but really be there as that calm co-regulator. And I guess a lot of the things too is it's not about offering advice or offering you should do this or you should do that or you need to do this. So we sort of head into that language base of there's always more than one truth to a situation. There's always many different ways. And what you might sort of find in when you're working with co-regulation is something that might work one day, might not work the next. And it's all about how that person's profile and how your profile is sitting on that in that any one time.
Sorry, I'm just I'm going through the.
So somebody said too that the duration of OT sessions and the overall length of treatment of individuals BTP can vary. That's exactly right. And so I couldn't really guess a minimum amount of sessions. The way that, so I am now only working with teens and families who are in, well, not teens, adults, families who are in crisis, to sort of really work on, first of all, let's map out what your profile is, and let's work out what your strengths are. It depends on how much crisis that person is in at the time. And then let's look at environmental adjustments. So we kind of work on all of those first three areas: relationship, environmental adjustments, understanding profile first. And then from that, we kind of go, well, what do we want to do next? And so then some people might, so there's not many opportunities in Hobart to go through DBT programs down here or in Tasmania. So we don't have any DBT programs offered for teenagers. We don't have any hospitals that would offer crisis support with a group program. We don't have any DBT groups, and so you might find an individual therapist here, but there's not a whole program for DBT down here at all. So we have a very vulnerable teenage population down here who have multiple hospital admissions and a high rate of suicide. So that's something that we would really, really love to change, but we are a small private practice. Well, not a small, we're a big private practice, but up against a medical system who we need to try and influence to change to be able to provide more funding for this whole process. And so it means that people would kind of might end up here just at a point of crisis, but we wouldn't advertise that we do a lot of this work because we just don't have the numbers to be able to provide the service.
That sounds really challenging. A few people have asked about understanding their own profile, or about understanding someone else's. How would they be able to go about some of that without using an OT if they didn't have access to an OT?
There's definitely some websites out there where you can get a lot better understanding of your own sensory profile, particularly, and I have included that I'll include those in the PowerPoints as well.
Great, wonderful. So I will also share some more information and registration about our Family Connections program. And for those of you who aren't registered on our database, I'll invite you to fill out a registration form if you'd like to learn more about the programs that we do. And even though we do come from a BPD perspective, someone doesn't need to have a formal diagnosis for their family and carers to come along to a Family Connections program. I will make a mention, though, we don't talk about anything other neurodiversities within the program. So it's very much from a BPD lens. So if there's BPD traits, if the person who you are in a relationship has BPD traits, then you are welcome to come along. But just remember that, I know, because I'm guessing that a lot of people here tonight have got children or family members with the neurodiversity, particularly autism. And we don't focus much on that at all. And that's just a gap where we are at the moment.
But I also think too, the great thing, like most of the families that I'm seeing, I would recommend and refer them through to that process as well. And I think actually having many different angles and avenues on it is perfect, because there's many things that you can apply in many situations, and sometimes it's also just about your own understanding yourself in that whole process as well. So I think the Family Connections program does that incredibly well.
Yeah,
I've had really good feedback from our families about it.
Yes, absolutely. Yes, we definitely don't want to be exclusive, but I also just wanted to put it out there as well.
Yeah.
But certainly in terms of the skills that you will learn, the validation skills and the self-validation skills, and having more of an understanding of where your limits are as well. They're all things that we teach in the Family Connections course. Let me go back and have a look here. Some people have asked about NDIS funding for BPD. I don't know if you have any information on that at all, Alison.
Yeah, look, the NDIS it's a national disability insurance scheme, so it's an insurance scheme, and the NDIS is for people who have a lifelong disability that impacts on their capacity to function and participate in their in the community, in their home, and in their social settings. So if somebody has a diagnosis, they'd be assessed to see how much their long-term disability impacts on their capacity for participation. So that's often done again by an occupational therapist, where they look at somebody's functional capacity and how much that impacts on engagement and participation. And from that, the NDIS would determine if you're eligible. And so, yes, we do have people who are on the NDIS who have psychosocial disabilities. If you have a diagnosis of autism, you are likely to be able to get on the NDIS if you have a full functional capacity assessment done that indicates your level of capacity to participate in everyday life. So I think our OT is here who does a lot of our FCAs. Are you here, Kez? Put in the chat. Q-Yan. Oh, she might have gone. She was here earlier.
No, I can see someone with that name.
Yeah.
Who's smiling knowingly.
Yeah. Yeah, I'm here. Yeah, so Kerry Ann does a lot of our FCAs for people who have psychosocial disabilities.
We've had a few questions come through as well, and this is a very common question. We get this almost every webinar, and it comes up a lot in our programs as well. And it's how best do we support someone who is refusing support themselves, so refusing professional support, refusing diagnosis, or
just to answer that question, it also just popped up, is it no, sorry, I don't know any OTs in Melbourne. So how do we support somebody who refuses support, which is actually one of the biggest things about BDP, isn't it? Is that whole difficulties recognizing where you're at, that that is such a common trait. But I guess the first thing that needs to be available is you being available, and you being building that relationship to actually gain trust and control, because you're with somebody who's feeling really scared and out of control and not sure what's happening for them or what to do. And when you're in that state of crisis, being able to see things clearly, because your window of tolerance is so tiny, is super hard. So just getting to that first point can actually be really tough, and it might take a long time. Everybody's journey is going to be different in terms of length. I can't sort of say that things will be better in a week's time or a year's time. It just depends on that person.
There's, certainly in Family Connections, we practice those skills of validation, which is validating where you're at and validating where the other person is at. And over and over and over again, we go very, very deep into that skill, and which is essentially, like you said, being present to the other person and what's going on for them, and being available for them. There is actually a wonderful video series called Open Your Mind Before You Open Your Mouth. And it's made by the Irish, I guess, sister organisation to ours. I'll see if I can find a link and send you a link to that. That goes through a lot of the skills that are taught in family connections, but it goes through a lot of role playing and family dynamics, and talks about how a validating environment for someone who's experiencing dysregulation, how effective that is, and what also, conversely, what an invalidating environment looks like. So that can be really helpful with learning some of the really key skills.
And look, I guess some of the things that we would go through, well, I would go through when I was working with a family is, often that just brought up a really good point about open your mind before you open your mouth. So when we look at neurodiversity, neurodiversity is often genetic. So it's handed down through families. And we would often see, a person who might have ADHD, or a parent who might have ADHD or be autistic themselves, really struggling around how I can actually use my language to validate, because, that's exactly it. Open your mind before you open your mouth. If you've got an ADHD parent, that's really tough for them. And so actually them understanding their profile and actually what happens for them as well is super important. And then just also going back to that whole validation happens across your whole environment, your living spaces, everything. Oh, great. Thanks, Kez. There's Kerry-Ann's just put up a link there about for psychosocial disabilities and access to the NDIS and how you do it.
Okay, let me have a look through some of our other questions.
Yeah, the wearing down with guilt, Jen, is a really interesting one. And that's a really important one to be able to work on your own self-reflection on that, to remap some of those emotions that might be coming up as guilt as actually that, I don't know, just not as that emotion, I guess, because yes, we feel guilty, we feel terrible for our kids, but then if we can actually work on our own stuff and pop some of those emotions into something a bit more positive in a strength-based way, that actually gives you a better foundation to be available for your person.
That seems to be definitely a theme of a lot of questions is, yeah, how can I support them when I'm feeling so terrible or so affected, so tired, exhausted, all of those things.
One of the things that I really got out of DBT, so when Steve said to me, you should look at this, and I went, oh yeah, whatever, shut up. So then I just went and did the whole training instead, rather than just delving into it in a little way, is that the biggest learning that I got from it, and we've talked about a lot of this when we've been running our own DBT group amongst our staff, is that the only thing that you control is your own thoughts and feelings. You can't control or begin to understand the thoughts and feelings of somebody else. And then the only thing that you can control is your own emotions and your own emotional responses to things. And so just on a personal level, I had to work really hard on my emotional responses to see where they were coming from. If I was feeling guilt, I was kind of like, well, where's that coming from? Is that because I feel like that my expectations haven't been met, and reframing that for myself so that I could shift that from a guilt emotion to actually, I don't need to be feeling guilt for this. I can actually feel something else to be there to be supportive. And that for me was a year of work in itself.
Trying to go through the chat, but I'm also listening to your answers at the same time. This has been a really wonderful webinar, very informative.
So that's what I guess I was meaning before, is that this is your journey as much as the journey of your person. And while we've had a tough year or two, I wouldn't take it back for the world, because now where we're at compared to 2 years ago, I just learned so much about myself, and so much about so many things, that I'm really grateful for that. Oh, so somebody's just talking about interoception as well. So that's tricky, isn't it? Because if you don't have good interoception, is the way that you can feel what's happening on the inside of your body. So a lot of people with neurodiversity find it really hard to actually map what's happening internally. So the hunger thirst cycle isn't as robust, and you can't kind of understand if you're hungry or thirsty, and that then can trigger emotional dysregulation because you're hungry but you can't feel it. Also, it's really hard to understand your heart rate and how fast it's beating. And when you're in that, so what will happen is when you release cortisol, all of those things will start to amplify, and that will make your anxiety worse, of course. But if you can't actually interpret what's happening, that confounds it enormously. Yeah, Rosie, some of the interoception learning is great that's out there. So Rosie, who's an OT, who's on here tonight, said that some of the interoceptive learning has been great. And that's actually through, there's a lot of learning out there on interoception, especially by Kelly Maher. Mailer. I'll put that in the link as well.
Anyone else got any more questions?
Or somebody feels like their question wasn't answered.
Yep.
They want to put it in again.
One that I've just found in the pre-submitted questions was, any suggestions on how to reduce trauma associated with a location that someone can't avoid? Example is their home, but the original trauma is no longer there.
So somebody's experienced trauma through a traumatic event or through their own neurological profile?
There isn't any further information on that one.
Okay. And then Monzi just said that Nina's question was missed. Nina, what did you ask? What about imagined trauma? I don't think there is actually imagined trauma. I think that trauma is mapped in so many different ways for different people. And so if somebody's mapping trauma, then it is trauma, because that's how their brain wiring will perceive it. So trauma doesn't have to come from an event. Trauma can come from the way that your brain is wired.
And I think you explained before with that extra sensitive nervous system. And so if the people have got the extra, auditory senses, then, and they've got a sensitivity to noise, then that's the trauma in itself, but it might not be traumatic to somebody else.
So that sensory modulation difficulty, it sits within a sensory processing disorder. So people who have a neurological profile for sensory processing disorder are highly likely to have massive big emotional responses throughout their whole life, but that'll be exacerbated when they hit teenage years as well. And that's when we'd see those increased diagnoses of borderline personality disorder. How do we balance being the person sought out for co-regulation with modelling and holding safe and healthy boundaries in the relationship with your person? Thanks, Neen. Like I was sort of saying, that's a real journey, and it changes over time. So I guess if I was to reflect as an OT on my own daughter, is that she still requires co-regulation, and it's changed and morphed over time as she has grown older. And still, as a 17-year-old, in our worst time, she still needs to curl up on my lap and I hold her and rock her, which is better than when she used to call me an effing whatever in the middle of the night in the middle of the street. But co-regulation can take many different forms and will morph and change over time according to that person and where they're at, according to where you're at, and also according to where your relationship is at. And if you think about it, most of us go back for co-regulation when we're under stress. And so, I might go to a friend or to somebody who I feel safe with to get co-regulation as an adult, or even as adults with a parent, if that is a safe relationship, you would often go back to your parent for co-regulation as well. So that search for co-regulation actually doesn't stop. We seek co-regulation all of the time when we're under stress. There's another question that's come through. Yeah, so all of those things, so the connection with craft, nature, all of that sort of stuff, absolutely, they're the things that get those lovely happy hormone juices going. But when you're in a state of crisis, being able to even get out of your bed to get to those things is so tough. To be able to get out of bed to go to an appointment is so tough. It's really tricky. And so, sometimes as OTs, we actually go in to the environment and work within the environment rather than in a clinic. Also, our clinics are all set up with spaces for regulation. Sorry, Sean, missed the other bit of the question. So I hope that was helpful tonight. I hope that you guys felt like you got some tips out of that and that you could walk away with a few strategies.
It was really fantastic. Thank you, Alison. I certainly really enjoyed your presentation today, and I think I'm going to watch the recording again, although I'll probably cringe looking at myself the entire time. But I really have enjoyed your presentation, and there's a lot of really wonderful tips in here.
Yeah, look, and I'm happy to, like I gave you a really big fat overview, and I'm happy if you wanted to ever drill down a little bit more into any certain topic, I'm happy to do that in a lot more detail and give you much more specific strategies that you could use.
Thank you. I'm sure we would like to do that. Well, thank you so much for sharing your knowledge, your experience, and your time with us today. We really appreciate it. And
Beautiful.
Thank you to all of our audience as well for your support, for showing up today for yourselves and for your relationships. I'm going to pop a little link in here if you would like to ask us any more questions. Then you can send us an email here to familyconnections@bpdaustralia.org, and along with the recording, which I'll send out within the next couple of weeks, Alison's going to grab a whole lot of links together for you, and we'll be able to provide the slides as well. I think that's it, and I will also send you all an invitation to register for our Family Connections program if you feel that that's something that your family would benefit from.
Thanks for the invitation, Belinda. Thanks, Steve, for putting a bomb under me and making me do it. And thanks also to the ICOP people out there who came tonight. Good on you guys. And thanks to everybody who attended. See ya. Oh, thanks to the other family who came too. Good on you. Bye.
Thank you.